Welcome. My name is Cindy Cavalucci, Director of Development with the Division of Philanthropic and Alumni Engagement at the University of Pittsburgh and UPMC. Thank you for joining us for our first virtual event, Inside Dermatology, which is produced in partnership by the Department of Dermatology at UPMC and our academic partners at the University of Pittsburgh School of Medicine. The goal of this series is to connect patients and advocates to the amazing work our dermatology teams are doing and to highlight some of our research priorities. Following the presentations, we'll take as many questions as time allows. We encourage you to put your questions in the Q&A tab at the bottom of your screen throughout the event. You do not need to wait for the Q&A to begin. Today, I'm pleased to welcome Dr. Melissa Pugliano-Mauro, Dr. Laura Ferris, and Dr. Yuri Bunimovich to discuss skin cancer risk, treatment, and prevention. It is my pleasure to first introduce Dr. Pugliano-Mauro. She joined the Department of Dermatology in 2010 and is currently the director of the Mohs Surgery program, clinic director and clinical laboratory director of UPMC St. Margaret Dermatology. Dr. Pugliano-Mauro also oversees the residency and fellowship programs at the University of Pittsburgh Department of Dermatology. She'll get us started with an overview on skin cancer, immunosuppression, and the transplant clinic. Dr. Pugliano-Mauro?
All right, thank you everyone for coming. Today I'm going to start with an overview of non-melanoma skin cancer, and then my colleagues are going to be predominantly reviewing melanoma. So this is just a brief overview. We're going to review some types of skin cancer, the development, high-risk populations, and some prevention. So just to start off with some fun facts, and you can find this from the Dermatology Foundation at skincancer.org. 1 in 5 Americans will develop some form of skin cancer by the age of 70. There are more than 5.4 million cases diagnosed per year. More than two people die from the disease every hour. And skin cancer is the most common form of cancer in the United States. It's more than the combined incidence of breast, prostate, lung, and colon cancer. Your risk of melanoma doubles if you've had more than 5 sunburns. And when detected early, the 5-year survival rate of melanoma is quite high at 99%. The cost of non-melanoma skin cancer has been exponentially increasing over the last several decades. And if you use SPF sunscreen of 15 or higher, it will reduce your risk of developing melanoma by 50%, and that is squamous cell carcinoma by 40%. So if we find skin cancer early, we can prevent it, and we can do some prevention, and we can also treat it as well. So just a nice intro just to sort of what we'll all be talking about. When I think of skin cancer, I think of it in this umbrella term, and I like to divide it into melanoma and then non-melanoma. And as I said, I'll be focusing on the non-melanoma skin cancer. So let's start with basal cell carcinoma. This is the most common type of non-melanoma skin cancer. Classically, it presents as a pink, pearly, what we call papule, with a central erosion. And you can see in the lower right-hand picture that it looks sort of like what we call a rodent ulcer. It doesn't just occur in light skin tones, but also in dark. And you can see on the lower picture on the left that it does have a sort of a grayish black appearance as well. Typically, these are slow growing and occur on sun-exposed sites. Common history of patients are that the area bleeds and just doesn't want to heal. Those at risk are really fair-skinned individuals who've had a lot of cumulative sun exposure, both in their occupation as well as recreationally. Those who've had a personal or family history of basal cell, as well as injury to the skin, and of course, immunosuppression, which we will touch on shortly. Squamous cell carcinoma is the second most common skin cancer and the one that's probably most near and dear to my heart. This causes the most deaths of the non-melanoma skin cancer varieties and is thought to arise from very short bursts of intense sun exposure. These can also be virally driven. The human papilloma virus can cause squamous cell carcinomas, most commonly on the nail bed, the fingers, toenails, or genital areas. These present as rough, pink or red, brown, scaly, even warty-like bumps that can crop up really quite quickly. And one picture shows one even growing, you can see under the nail plate itself. They can be quite extensive and disfiguring. They can be difficult to clear as well as repair. And we worry for the concern for metastasis or spread when they have the following features. If they're larger than 2 centimeters in size, if they're located on the lip, the ear, the nose, or if they have aggressive pathology when you look at them under the microscope, including some wrapping around of a nerve. And then especially in immune suppressed patients, because there's just not as much surveillance in these patients to help them repair damage. So skin cancer is the most common cancer in patients who have received a solid organ transplant. So those who have had received like a liver, lung, hearts, pancreas, and they become a challenge to the dermatologist simply because these skin cancers crop up quite early and patients can have a very high tumor burden. And so oftentimes these patients become very good friends of ours, and we're seeing them quite frequently because of the number of skin cancers they have. Here at UPMC, we have a specialized dedicated clinic devoted to these solid organ transplant patients. And we do pre and post skin examinations, take care of course, all dermatologic diseases, as well as provide comprehensive dermatologic surgery for them as well. These are just some of my colleagues who participate in this clinic. And we have another colleague joining us. And quite certainly, most of our dermatologists here at our department can take care of transplant patients well. And we all, discuss and work collegial and, where any dermatologist here can help you out. So why is it that solid organ transplant recipients develop skin cancer? Predominantly, it's because of the immune suppressing medications that patients are on, and there's a list that you can see for yourself. But it's really two distinct mechanisms. One, these drugs in and of themselves can be directly carcinogenic, meaning they cause cancer. And second, the immune suppression impairs surveillance, and so you cannot recognize damage and eradicate sort of pre-skin cancer changes, and so they progress. Other risk factors for the development of non-melanoma skin cancer in these patients are if you have what we call thoracic organ that's been transplanted, heart or lungs. That's due to the increased amount of immune suppression you have to be on in order to avoid rejection of those organs. Fair color of your skin, your eyes and your hair, your cumulative ultraviolet radiation exposure, being 50 or older at the time of transplantation, the duration, so the longer you get out, the more likely it's possible, being of male sex and having a personal prior history of skin cancer. This is just someone who has a kidney transplant, is on immune suppression, and you can see how quite high the tumor burden can be. This is the patient's first visit, and we did, 19 is what you can see biopsies of skin cancers that were present. So squamous cell carcinoma in solid organ transplant patients poses a risk because it's so common. It's 65 to 200-fold greater in this population. And the interval when it occurs is typically about 8 to 10 years, but those individuals can have as high as a 70% incidence of 20 years. And why do we care? Because they tend to be more aggressive in this population. There's an increased risk of metastasis, as well as a mortality over that of the general population. And just to show you, UPMC participated in a nationwide transplant study where we were looking at the incidence of skin cancer in these patients. We contributed over 800, meaning we were the second largest transplant center in the United States. And skin cancer, they looked specifically at the incidence. So our patients are in this study, that the incidence rate of squamous cell carcinoma is about 1,300 per 100,000 person years. And to put that into perspective, breast cancer, which is the most common cancer in the US currently, is only at 125. So you can see how squamous cell carcinoma is a really important skin cancer for us to focus on in this population. Of course, you can develop other non-melanoma skin cancers. Your risk of basal cell is 10 times higher than the population. And then, of course, there are other skin cancers that are a little bit more rare, but Kaposi sarcoma, Merkel cell carcinoma, and other T and B cell lymphomas, which can oftentimes look like a basal cell carcinoma. Often we use something called Mohs surgery. This is a specialized both surgical and histological technique pioneered by the individual Frederick Mohs. People often call it Mohs surgery, and I'm like, I have to tell them, no, it's Mohs surgery. It's named after the individual. We use it for cosmetically sensitive areas like the head and neck, hands and feet, or genitals. We use it for large or aggressive or recurrent skin cancers, as well as in the immune suppressed population. The goal of this surgery is to have a higher cure rate. It also minimizes the sacrificing of normal skin to obtain clear margins, and also helps to maximize cosmetic outcome because you don't have to do as large of a repair. Here are the basics on Mohs, and you can see a lesion on the top left. You mark a clinical margin with about 1 to 2 millimeters, and you remove in a saucer shape sort of excision And then, you check this tumor under the microscope while the patient is there, and you repeat the steps until you get clear margins, and you really can gather sort of fine extension of tumor. The key concept of Mohs surgery in comparison to regular pathology is that 100% of the margin is evaluated. Additionally, the surgeon is the pathologist, so there's no middleman. I know exactly where the tumor was on the patient. When I find the positive margin, I can go right back to where I was working. I can even bring the slides to the bedside on the patient and hold it up and go back to where the last bit of tumor is left over. For a side-to-side comparison, this is how you histologically prep Mohs, and you can see the saucer shape that was taken in this small stepwise approach to making sure that all bits of tumor extension are taken out. And when you look on the right, if you do a conventional excision, you take sort of a very large piece of tissue, and it is then sent to a pathology lab where it's bread loaf. So what you could imagine is that large piece of tissue is a piece of bread, and they cut a slice at A, at B, and C. And when you look at the lower circle, you can see A, B, and C is clear, but we've missed a couple of slices in between where the red arrow is. And so we have this risk of missing subclinical extension and potentially leaving behind a positive margin. This is showing the same exact thing. And I'm Italian, so I like food. So I like to say, like, here's the loaf of bread. And if I picked the piece of bread that didn't have mold in it and I missed the one with mold, which has skin cancer in it, I'd be leaving behind or potentially eating something pretty toxic. So that's sort of how I show you the difference between what we do in Mohs and what's happening if you just do a conventional excision. Here's a patient that shows that he is a basal cell that looks very well delineated on the left upper ear, but after 3 stages of Mohs surgery, we have to take a significant amount of more tissue to clear. This is someone younger who has a typical straightforward basal cell. This gentleman is in his late 20s. You wouldn't think that it would have gone this deep, but after 6 stages, we're able to clear him. And we're also able to repair him that same day. He leaves knowing he's clear of tumor. This is him at 1 week having a pretty nice result right in the office, all done with local anesthesia. Mohs surgery is very important in solid organ transplant recipients because studies have shown that those who have solid organ transplants, as well as those with hematologic neoplasms such as CLL, are at increased risk for this subclinical extension. So if you look at this gentleman, this is also a young lung transplant patient. It doesn't look like there's much going on both of those sites, but when we're finished clearing him, we've even had to remove some cartilage. And so you can see the value and the benefit of Mohs. And this gentleman's able to keep the contour of his ear when we're all done. This is another transplant patient with a squamous cell carcinoma on the nail bed, and we're able to map this out very nicely, and we are able to spare his digit. In the past, you would just have amputated at the last joint, and here he is in follow-up, and even his nail plate has grown back quite nicely. So last, I'm just going to say a couple of words on prevention of skin cancer. I'm going to leave sunscreen to my colleague, Dr. Ferris, but in addition to sunscreen, cover up. They do make sunscreen with built-in, it's not built-in, it's called UPF. It's the weave of the clothing that helps to protect you. Accessorize, wear hat, remember the sunglasses because ultraviolet light causes cataracts, and try to avoid glare, especially if you're skiing. The higher the altitude, the increase of your risk and exposure to ultraviolet radiation. And then just in a note, this is kind of hot in the, a hot topic these days is that chemoprophylaxis with a B vitamin called nicotinamide, which you can purchase over the counter. This is a vitamin B3 supplementation, and you're looking for nicotinamide, not niacin. Niacin makes you flush, and that's not what you're looking for. But the nicotinamide, as you can see on the right corner here, it boosts cellular energy, and it may enhance energy-dependent cellular processes such as DNA repair. So it kind of shifts this whole image, if you see the DNA damage and aging and ultraviolet damage, to this DNA repair mode, and sort of works as almost like an antioxidant. The original study that was done for this supplement was in about 2015, and it was a hot topic in the New England Journal of Medicine. This supplement was tested in those who have had a history of skin cancer, or at least two non-melanoma skin cancers in the last 5 years. The supplementation is 500 twice a day, and it did show a reduction of a new non-melanoma skin cancer by 23%. 20% fewer BCCs or basal cells, 30 of SCCs. And while it wasn't significant, it also reduced actinic keratoses that are the pre-skin cancers to squamous cell carcinoma. Unfortunately, this study was not done in immune suppressed patients. The same authors did go back and try to do this study a little bit later. Unfortunately, the numbers are really quite small. And so while there were some improvements, they weren't significant. It also wasn't so great in helping to prevent sort of aggressive forms of the cancers. So we definitely need to wait for some more trials. But then this trial came out that was promising, that showed that in the setting, at least of kidney transplant patients, that it did prevent actinic keratoses, which are pre-skin cancers. But moreover, I think what's most important for these individuals is that this supplement doesn't interfere with your immune suppression drugs. And that's really important because obviously we don't want to alter those and risk rejection of your organ. Again, larger follow-up studies are needed in this population. So that what I'm doing here at UPMC is I'm trying to understand the need for pre and post surgical prophylactic antibiotics in the solid organ transplant population. Also looking at, with Dr. Ferris, we're thinking about looking at a baseline evaluation of ultraviolet damage in transplant patients prior to transplantation. So maybe we can predict who is going to develop more and keep an eye on them more closely. Looking at the role of adjuvant radiation for the treatment of high-risk squamous cell carcinoma, as well as I have a strong interest in intralesional chemotherapy for the treatment of squamous cell carcinomas on the lower legs. So that's sort of non-melanoma skin cancer in a nutshell, some touch points on immune suppression, prevention, and these are just some of my patients. This is Daffodil Day. It happens every February, and I called them all last night. They all said I could use these pictures. It's the American Cancers Day to just provide hope, and so we delivered daffodils to all of our Mohs patients that day, and you know, we have a great job because we get to provide a cure most days that we get to work. So with that being said, thank you for listening. I'm going to stop sharing my screen, and next up is Dr. Laura Ferris, both my partner, I'd say in crime and at our office, and we'll let her get started.
Great, thank you so much, and I'm going to share my slides here. So I'm going to talk about melanoma before I turn it over to Dr. Bunimovich. So I'm going to focus on early melanoma, and then he's going to talk about late melanoma. So one of my interests is in how do we improve early detection of melanoma so that we can give less business to our colleagues over in oncology who have to treat this with more systemic therapy. So just a really quick review of how do we identify melanoma. You may have heard about the ABCDs. So we look for lesions on the skin that have asymmetry, border irregularities, 2 or more colors, a diameter greater than a pencil eraser. We also look for things like change. So a mole that gets bigger, particularly in a short period of time, is concerning. Regression is when the immune system starts to kick in and starts to get rid of a lesion. That usually means it was atypical, and that can be a sign of melanoma. And then finally, my favorite sign is the ugly duckling sign. If you stand back and look at somebody's moles in the mirror, the one that jumps out because it doesn't look like the other is concerning. I'm going to go over very quickly what we mean when we talk about early versus late melanoma. So like most cancers, melanoma is staged according to how advanced it is. So melanoma starts as a stage 0, which is melanoma in situ, or early stage 1 disease. As it becomes deeper and goes down deeper into the skin, or grows so rapidly that it breaks open the surface, causing an ulcer, that's stage 2 melanoma. If the melanoma breaks away from the primary site in the skin and travels to the draining lymph nodes, that's stage 3 melanoma. And then stage 4 melanoma is when the melanoma has spread really beyond the primary site and is in organs like the brain, liver, or lungs. So early detection is important because if we look at what proportion of people diagnosed with each stage of melanoma survive, we can see patients with melanoma in situ, essentially nobody dies. It's 100% curable with a surgery in our office. Stage 1 melanoma has a better prognosis, and then it goes down until you get to stage 4 melanoma. I think one of the interesting things about melanoma as opposed to other cancers or skin cancer in general is that if you look at who initially detects it. So for example, it's essentially impossible to detect your own colon cancer, breast cancer, pancreatic cancer at an early stage. But about half of all melanomas are diagnosed initially by the patient and the other half by physicians. I will say that notably, melanomas diagnosed by the patients tend to be a little thicker or deeper, meaning a worse prognosis than those diagnosed by physicians. But I think that's a really great area for improvement. So making a melanoma diagnosis can be really easy. So I think anybody would look at these lesions here and say, well, clearly that's not good. But it can also be really hard. So these are two early melanomas that were very subtle. And so I think we need to think about how do we do a better job of identifying the subtle melanomas, and how do we make sure we find melanoma before they get to the stages on the left. I will say melanoma can have lots of different appearances. So these are all different relatively late stage melanomas here. So anything that doesn't look right, that grows rapidly, that's different from other moles, deserves medical attention from a board certified dermatologist. We are really interested in melanoma screening here at UPMC. So we have an initiative that we started back in 2014. And this was not a clinical trial or a study, but a quality initiative where we worked together. I did this with Dr. Kirkwood, who is a medical oncologist, who's a world-renowned melanoma expert as well, and also with Dr. Fran Solano, who helps to run our primary care practices at UPMC. And so we designed a voluntary initiative where primary care providers were given access to an online training module to teach them how to say what is potentially melanoma or non-melanoma skin cancer, what are things that can mimic it but are not, and to teach them to do a basic skin exam, not like what you would get at a dermatologist, but a basic survey of the skin when they're looking at patients 35 and older once a year and during a routine visit. And then we modified our health record to be able to have them just click a button to say, hey, I screened this patient, or this patient told me that they were screened in the past year. And then from that, we know who's been screened, roughly when it might have happened. And then we can also pull, because we have electronic health records, things like who was screened, when were they screened, and who developed melanoma and what did they look like. So I'm just going to do a quick reminder here that, like I said, melanoma thickness is an important part of staging. The thicker melanoma is, the worse the prognosis. So if I talk about melanoma in situ, that means it hasn't broken through the first layer of skin. That's the most curable one. T1 melanomas are ones that are a millimeter or thinner. And then when we talk about thick melanoma, once a melanoma hits a thickness of 4 millimeters, that has a much worse prognosis. That's the pink line looking at survival. You can see it's much lower than it is, for example, the hot pink line at the top for the early stage 1 melanoma. So our goal is to find and get rid of melanoma when it's thin, and to prevent the development of thick melanoma. So what we did here is, this is looking at data from UPMC. So we looked at all the patients who were screened, and they're the red lines. And then we looked at the patients who were unscreened. So they would have been eligible to be screened, but for some reason they were not. And what we can see here is we looked at everybody, people who were older than 50 and people who are older than 65. The reason why that's important is we know that the average age at diagnosis of melanoma is 65. The average age at death is 71. So that's probably where we're going to have the most impact, is in patients who are over 65. So what we can see here is that patients who were screened, we found a lot more melanoma in situ when we screened them than we did than if we just let them come in on their own complaining of a lesion. If we look at thin melanomas, we also see more thin melanomas in those people who were screened, the red. Now, if we look here at thicker melanomas, we see that things start to flip. So when we just look at everything thicker than a millimeter, the number of melanomas that are detected look pretty similar in the screened and unscreened patients. However, when we start to look at thick melanomas, so thicker than 4 millimeters, these are the most deadly melanomas, we actually see that the roles are reversed. So unscreened patients develop more thick melanomas later. And this is particularly true as we look at an older population. So if we look at just focusing on the bottom right, for patients over 65, we see that the unscreened patients are more likely to develop thick melanoma. Our hypothesis here is that because patients are getting screened, we find that melanoma, they're falling into that 1 millimeter group. And so their melanomas don't progress and become thick and more deadly. So one of the questions that we often get is, well, should I see a dermatologist for a skin check? Who should and how often? And, this is an article that I saw in a magazine about when Jennifer Garner was even younger than she is now in her 30s, saying, well, as a 30-year-old woman, I'm going to see my dermatologist every single year and do a skin self-exam every single month. It turns out that, when we look at this scientifically, we have a body called the United States Preventive Services Task Force, and they make recommendations about things like cancer screening, who should get a mammogram, who needs a colonoscopy, when. And they have actually concluded not that we shouldn't do any kind of skin cancer screening, but that we actually don't have enough evidence to assess the benefits versus the harms of screening, or to show that screening really works. So one of my kind of career goals has been, let's try to get the data that we need so that we can make more evidence-based recommendations. And now I will say what they mean is a full body visual examination of the skin in somebody who is symptomatic. They don't mean if you have something growing, you shouldn't get it looked at. And so that's really the difference between surveillance, which is following people who have a disease to find recurrence earlier or to find new melanomas or skin cancers earlier, versus screening. Screening is you've never had a skin cancer, you don't have significant risk factors, and we're looking at you when you have no symptoms, you don't have anything suspicious. So the American Academy of Dermatology does recommend surveillance. So patients who have had melanoma should be seen somewhere from every 6 months to once a year. We also do want to keep a close eye on patients who have risk factors like a previous non-melanoma skin cancer, a strong family history. So how can we improve early detection? I think better public education, so patients know that something is suspicious and seek care earlier. And then improving detection particularly by healthcare providers of some of these subtle lesions. So there's some technologies that we'll use for patients who have a lot of atypical moles. It can be hard to find that needle in the haystack, that one mole that's changing. So for some patients, we will use mole mapping, where we take serial images of the body, and then we can use that as a baseline. And if I see a mole I'm worried about, I can tell if it's new or changed or not. Even further beyond this, we're trying to use artificial intelligence to actually have a computer do those comparisons and pick those out too. You may have noticed that we all use dermatoscopes, which are these handheld tools. They give us a better view of a lesion and give us information we can't see with our naked eye. So this is a melanoma in the top left. You can see this is what we would see if I just took a photograph. Through a dermatoscope, I can see features that let me know that this is concerning, like an area of the pigment network that's atypical, or abrupt. I can see how abruptly the pigment cuts off, and I couldn't see that without it. And we know that in the hands of trained people, this increases our ability to find more melanomas, and it also increases our ability to say, you know what, that's a benign mole, that doesn't need a biopsy. Another test that we use sometimes is a way to non-invasively get a look at the genetics of a mole. It's a piece of tape that goes over that lesion. We can then take that off and send it out, and we can look at gene expression. So a benign mole might express this blue gene at a high level, whereas melanoma won't have it at all or at a high level. And then the yellow gene, if that's present, would give you a sign to us that, this is concerning for melanoma. So this is a way to get an answer without always having to do a biopsy, and it's appropriate in some situations. So finally, I'll wrap up with prevention. In medicine, our most rigorous studies are randomized controlled trials, ideally with placebo. This one wasn't done with placebo. This was 2 groups of patients were given sunscreen and said, put this on all your exposed skin every day. And another group was just said, do whatever you normally do for sun protection. It turned out that when we look at the new cases of melanoma over time, we can see that the patients who were given sunscreen in the blue had fewer new melanomas. And this was really significant because the risk of melanoma went down by 50%. And their risk of invasive melanoma, the worst ones, was actually reduced by over 70%. And that when they did get invasive melanomas, they're actually thinner than they were in the patients who were not given sunscreen. And finally, This is a supplement. You know, Dr. Pugliano ended on a supplement. I'll end on mine. This is a Fern extract. This is, I will say there's no data to say that this prevents skin cancer, but I find this to be something interesting. This is a small study where patients were either given placebo or a supplement with a Fern extract that they took twice a day. And if you look at the people who got the Fern extract are the black bars, those who got placebo are white. You see a higher rate of people having, they were also still told to use sunscreen, of having no sunburns if they were given the Fern extract than if they got placebo. And you see a higher rate of sunburns, also a higher rate of ultraviolet induced redness in patients who got placebo than those who got the Fern extract. So, you know, there's a potential to learn so much more. I think we have a great resource in our screening data at UPMC, but we need to answer bigger questions. Does our screening prevent death? How often should we be screening? What can we do to help prevent melanoma? Which patients are going to benefit the most from screening? I think we saw from our data that it's probably going to be older patients, not everybody. How can we help patients find their own melanoma earlier? And then how do we determine not all melanomas are equally aggressive? How do we find the most aggressive ones? And really, we need this kind of data to generate evidence-based recommendations and guidelines. So thank you. I am now going to turn this over to Dr. Yuri Bunimovich, who's going to talk about more advanced melanoma.
Hello, everyone. I also want to, again, thank everyone for tuning in today. I want to thank my colleagues for a wonderful presentation so far. With that, I want to share my screen with you as well and begin the presentation. So I will talk more about the therapy that has come out over the last decade on advanced melanoma, and where is the research going, especially in our department, where is the research going in terms of melanoma. So as Dr. Ferris already mentioned, melanoma is really staged primarily by how thick it is and how deep it invades into the skin. I will primarily talk about the advanced melanoma that is stage 4, when the melanoma has basically spread from the initial area where it initiated to other organs in the body. So in order to understand some therapy that has come out, I want to introduce this concept of tumor microenvironment. So, and that made our advance of the therapy much more rapid over the last several decades. So it turns out that cancer doesn't exist in vacuum. It cannot survive by itself. It needs very specific other players around it in order to help it propagate. And so some of those players are your own cells that just happen to be around it, blood vessels, other cells, stromal cells. And also you have immune cells also coming into the skin, coming into the cancer, trying to fight it, trying to kill it. So one of those immune cells is called T cell. And the T cells are really the main cells your immune system employs to come and find and destroy the cancer cells in general, specifically for melanoma as well. So a lot of the therapy is aimed at boosting your own immune system, giving it more of a chance to be more effective at finding and then killing the cancer cells. So on this slide, the top box is essentially a timeline of the therapies for advanced melanoma that we have had over many years. And what may jump out at you is that for over 3-4 decades, we have had very little to no progress in the therapies that are available for patients with this deadly disease. And over the last decade or a little bit longer, there's really been an exponential increase in our understanding and also of the revolutionary therapies that have come out primarily for melanoma, but also actually that are effective against other types of cancer. And so the two types of therapies we'll talk about briefly are the targeted therapy and immunotherapy. So the targeted therapy, you can think about the cell as receiving signals from the outside. So cancer cells need stimulation to continue growing all the time, called growth factors. And so you can think about as having a Christmas lights, plugging in that Christmas light, and you're getting energy from that. And every light then turns on subsequent light as a chain reaction. And at the end of that, that propagates and turns on the uncontrolled growth of the cell. So on the bottom left, you see a box that on the left, you see a normal chain of events that normal cell would employ to grow. But cancer, melanoma, does something different. It bypasses the plug. It bypasses the energy socket. And it turns out that there are certain mutations in melanoma that keep the Christmas light on all the time, whether it gets growth signal from the outside or not. It always gets that stimulation to grow and grow and grow. So this BRAF gene is one of the major mutations in melanoma. So targeted therapy that has come out over the last 10 to 15 years are specific inhibitors, specific molecules that prevent the continuous activation of those Christmas lights and therefore inhibit the growth of melanoma that way. And when they came out, it's been a remarkable revolution when people who have had multiple metastatic lesions in their bodies suddenly saw them melt away in a very, very short span of time, within weeks to months. However, it turns out that melanoma is a very, very smart type of cancer, and it has been evolving ways to bypass our drugs. Essentially, instead of using that line of Christmas lights, it now then employs a different line of Christmas lights that can kind of give it the same stimulation. So what turned out was that these patients who have experienced a remarkable improvement then started relapsing. And so there is unfortunately, a fairly significant relapse rate for patients who have first responded to this class of medications. Now, the other type of therapy that has come out that has revolutionized our therapy for melanoma is a class of therapeutics called immunotherapies. So what these therapies do is they essentially help your own immune system to recognize and kill the melanoma cells better. So I mentioned already that T cell before, and these are professional immune cells that are designed to come in and feel out for tumor cells. And when they find it, they basically kill it. So on the bottom right, you see a schematic of this T cell in blue who has found a tumor cell, and it has engaged with it with these brown receptors, these brown docket. And that tells the cell, oh, this is a tumor cell, and I'm going to kill you. However, in order to keep check on your immune system, too much of immune stimulation is not good. Your body has these other receptors, other dockets called checkpoint inhibitors. And these dockets essentially keep tabs on the immune system so it doesn't get too active because it can cause harm that way. So as I mentioned, melanoma is extremely smart cancer. And what it has found is that if it basically puts these dockets around it, it can also control how T cells find it. Basically, if the T cell found it, it basically docks with it in that way and then say, hey, nothing to see here, and just move along, don't need to kill me. So these checkpoint inhibitors are one of the major reasons why melanoma can be silent and not be noticed by your immune system. So these immunotherapies that have come out are based on a class of medications called antibodies. You may have seen those advertised on TV, like medications like Humira, medication like Stelara, Cosentyx. They're used for actually many different conditions, diseases. And so in the last few years, these specific checkpoint inhibitors, they're called, came out. And what they do is they essentially interrupt the docking between the immune cell and the tumor cell that puts a check on the T cell. And once that is interrupted, T cell is now not inhibited anymore, and it can be activated in a much more effective way. And so they are called immunotherapies. So I wanted to mention, this is still, we're talking about 5 to 10 year research that has been carried out on these therapies. And so overall on the left, you see that this is a survival curve for patients with advanced melanoma. The bottom curve, this purple curve that says IL-2 alone, is what we used to have years ago, the survival for patients years ago. All the other ones, all the other curves, is how the survival of patients has improved as these therapies have come out. So unfortunately, as I said, some therapies are effective, but the melanoma finds a way around it. And for immunotherapies, there's been great success at increasing the overall survival, 5-6 year overall survival for patients, but melanoma still is finding ways around it. And we are, right now, this is a very, very hot area of research, is how is that happening? How we can improve the survival of patients who are receiving immunotherapies even further. And it's a tricky thing to do also because, you might ask, well, what if you just add different immunotherapies together? So what happens is immune system is always in a balance. Too much of a good thing is not good, unfortunately, it's like everything in life. So if you rev up your immune system too much by introducing several immunotherapy agents together, patients start suffering from autoimmune type conditions where your immune system does no longer just go after the cancer cells, it starts attacking normal cells in your body as well. And so clinicians in this situation walk a very fine line between having the best efficacy for melanoma versus controlling the adverse effects of too much of an activation of the immune system. I want to briefly switch to discussing just what the University of Pittsburgh and UPMC Department of Dermatology is involved in. We have a very active program in skin cancer research, melanoma in particular. I wanted to mention several major projects that are currently being carried out. One is on vaccines for melanoma. So Dr. Fehler, Dr. Yu, Dr. Korkmaz are involved in finding ways to find vaccines for melanoma, much like the vaccines you have received or hopefully going to receive soon for COVID. These are little pieces of melanoma, little pieces of DNA or other markers that serve as vaccines to educate your immune system to much better find and fight melanoma. That's one major project. Another major project is carried out by Dr. Storkus, and that has to do with how do we, in general, find other ways to improve the immune system response to melanoma, make it much more effective. And it has to do with these sting agonists I won't go too much into right now. Third project, near and dear to my heart, has to do with nerve innervations of melanoma. So I mentioned that tumor microenvironment is composed of many, many cells. So it turns out that nerves are also major players in the cancer microenvironment, and they can actually be supporting the progression of cancer, specifically melanoma. And we are currently actively investigating how the nerves are supporting melanoma progression and how we can block that. And last one, also near and dear to my heart, project is how do we find new ways, new pathways of cell death mechanisms which we can activate in melanoma to essentially kill it and leave the normal cells alone. So those are the major major projects that are being carried out in the Department of Dermatology. So with that, I would like to turn it over back and thank you.
Dr. Bunimovich, we have time for a few questions. We'll try to get through as many as we can with the time left. This one looks like it's for Dr. Pugliano-Mauro. Dr. Pugliano-Mauro, what are the latest developments in Mohs treatments or surgery?
Sure, can you hear me? So currently Mohs is predominantly done for non-melanoma skin cancer on the head and neck, but we definitely have started to find that it is also very helpful for the treatment of very superficial non-invasive melanoma called melanoma in situ and lentigo malignant melanoma, as well as some that are very, like Dr. Ferris talked about, very early stage that do not require any further treatment. We actually have validated those stains in our lab, and hopefully we'll soon be moving forward with starting some of those as well.
Thank you. The next question goes to Dr. Ferris. Given the large, extensive database, big data, created by UPMC's health and medical records, have any of the speakers had experience using data mining as a research technique?
Yeah, I think that's a great question. And I think that's one of the real benefits for me of being on faculty at Pitt and UPMC is that we do have access to not just great scientists and great epidemiologists, but also, tons and tons of important relevant data. So, what I showed in screening was essentially, it wasn't a clinical trial. That was really data mining. And so using what we can pull out of the health record to get information clinically, but there's a lot more that we can do. So, we want to be able to look at things like who has died. So in what cases can we say this group was screened or not, and the survival differed or it didn't. So there's a lot of questions we want to look at. We also want to, as the question asked about, things like we have UPMC health plans. So early on in this intervention, we did take some data from UPMC health plan to say, anytime you talk about a treatment, Dr. Bunimovich talked about the benefits and also the risks of some of the medications. You'd think a skin check has no risk or no harm, but it does, because it could drive lots and lots of unnecessary biopsies or lots of visits to dermatology that weren't really needed, meaning that then we're not seeing patients with severe skin disease, for example. So we were able to look at some UPMC health plan data to show that the patient in the group of patients who were eligible to be screened, they weren't having more visits. But that was really just scratching the surface of what's available. There's a lot more that we could be looking at. We could look at things like claims for some of these medications in patients who were screened or unscreened. So there's still a lot more to do, and it's a great resource to have.
Thank you, Dr. Ferris. Dr. Bunimovich, this looks like it's for you. I've had all three kinds of skin cancer. Recently, I had a squamous or basal cell cancer in a place where the sun doesn't shine. Does this mean that there is a systemic component to skin cancer?
I think you're muted.
I'm muted. Yeah, sorry. It's a great question. So it's a quite broad question, and I'll probably ask my colleagues to chime in as well. For melanoma, certainly we know that there is a systemic component to skin cancer. There are actually genetic mutations that one can acquire that would predispose one to melanoma, regardless of their sun exposure. For both melanoma and non-melanoma skin cancer, there are certainly also predisposition to skin cancer. Ultraviolet exposure is a big one, but if you have had skin cancer in places, areas where you haven't had much sun exposure, it could be for other factors. As I mentioned, immune system has a lot to do with surveilling your skin all the time for potential sporadic mutations you might have that predispose you to, that would lead to skin cancer. And so if there is some issues with immune surveillance, you could potentially develop skin cancer in areas that have not seen a lot of UV exposure. Basically there are systemic effects, and also, as I mentioned, innervation, stress on the body has a lot to do with whether one may be more likely to develop skin cancer. And maybe my colleagues will also have anything to add to this as well.
Yeah, I think you did a great job of covering that. So I think that there's the mutations that we know about, or there's the genetic factors we know about, and then there's the ones that we don't. So sometimes I'll send a patient who's had 5 melanomas before they're 50 to genetic counseling. They get screened for every known mutation and they don't have it. And they say, so great, so I'm not predisposed to melanoma. And my answer is, of course you are, because you've had 5 melanomas and you're not even 50 yet. I think we still have a lot to learn in that area. It probably has to do with, the patient who asked the question, if you've had 3, it's probably a combination of your sun exposure, but also, your, like Dr. Bunimovich said, your genetic risk profile. My guess is that person has fair skin, maybe light hair or light eyes. And there's probably more to it than that. We know patients who have had basal cell carcinoma actually have a higher risk of having other systemic malignancies, things like lung cancer or, pancreatic cancer. I'm just kind of throwing those off there. That's not necessarily the greatest risk in those, but there's probably something to do with, as Dr. Bunimovich mentioned, things like repairing mutations that occur sporadically in our bodies every day.
Thank you. Dr. Ferris, what barriers are in the current payment system for physicians that can limit your ability to prevent and treat skin cancers?
So that is a really interesting question. So as I mentioned, the Preventive Services Task Force has given an I rating to skin cancer screening. So for example, if the task force said we have no data to support colonoscopy as colon cancer screening or mammography, it would really limit access to those services, because there are guidelines that say, women over the age of, depending what you read, 40 or 50 should get a mammogram, or people at, 50 should start getting colonoscopies. We don't have that for skin cancer. So I can't see somebody and code for a visit purely and say, we don't get reimbursed to screen people for skin cancer. We do it because we think it's important. We will say we're seeing somebody because of a lesion of concern or because they're worried about their sun damage. But in general, we can't schedule somebody, and there is no place in the sort of current payment system to pay for skin cancer screening. So I think that that's why, and once we have guidelines and a recommendation to guide us, that will change. And so that's going to mean that more people are going to be willing to do skin cancer screening. And I think it's going to open up access a lot. The other thing is the medical coding system just changed. And interestingly, if I see you for acne and write you a prescription for acne, that actually reimburses better than if I say, I'm seeing this person, they've had 4 melanomas, I am going to look at every inch of their skin and screen them. That because it's not I'm not managing with a medication, that actually now gets paid significantly less. So I think that we need to really remember that, it's a great risk to do skin cancer screening. If I miss something, I open myself up to the terrible feeling that I missed your cancer or even legal liability. So I think that having data, generating firm guidelines so we screen the right people, but that we also make sure that those patients do have access to care is very important.
Thank you very much. I think we have about 5 minutes left. We have time for one more quick question. And I will ask you, Dr. Bunimovich, you mentioned that nerves can affect skin cancer growth. Is skin cancer usually painful? And does stress affect the risk of getting skin cancer?
Is skin cancer painful? Sometimes, yes. So we're still learning a lot about innervation of skin cancer. We know that sometimes squamous cell carcinoma can be painful. We don't yet know why. Most of melanoma and basal cell carcinoma tend not to be painful unless they, reach a certain large size where you're just pushing on the nerves, but by themselves, they don't seem to be painful. So pain may or may not be one symptom that you might feel, if you have skin cancer. In terms of stress, so that goes back years and years of research that clearly shows that stress, both emotional, physical, has a large component in making somebody more predisposed to skin cancer, and just to cancer in general, not just skin cancer. How that happens is a very, very active research area right now. We know that some of it directly has some of the stress has direct effect on stimulating cancer cells. We know that some of it has to do with actually suppressing your immune system and basically making you less able to fight skin cancer and cancer in general. So that is a great question, and it's a very active research area right now.
Thank you, Dr. Bunimovich. We are almost at the 1 o'clock hour, and I'd like to take this opportunity to thank all of you for taking the time to speak with us today and for all that you do for the Department of Dermatology, for UPMC, and the University of Pittsburgh. And to those of you who are joining us for this presentation, we thank you for entrusting us with your care and hope that you enjoyed the presentation and hearing more about the great work being done within our department. Please keep an eye out for future Inside Dermatology events. In the meantime, stay well and enjoy the warm temperatures.